Welcome to Mobile Medical Media's video tutorial on ultrasound evaluation of the aorta. This tutorial teaches you to identify the aorta and abdominal aortic aneurysms. A 65-year-old male with a history of diabetes and coronary artery disease is brought to the emergency department for left flank and abdominal pain. On examination, the patient is tachycardic and has a distended abdomen. An emergent CT scan is ordered to evaluate the patient for possible ruptured abdominal aortic aneurysm. Just prior to the CT scan, the patient becomes hypotensive. A bedside ultrasound is performed. Ruptured abdominal aortic aneurysm, abbreviated as AAA, is a life-threatening process with a high likelihood of mortality. Ultrasound is the diagnostic modality of choice in the patient who is too unstable to be safely transported to the CT scanner. In the stable patient as well, ultrasonographic evaluation for AAA is a well-accepted basic application of emergency ultrasound. The primary goal of aortic sonography is to identify aneurysms. An aneurysm of the abdominal aorta is defined as any dilatation greater than 3 centimeters in diameter. Older patients presenting with abdominal, back, or flank pain, as well as patients with hypotension of unknown etiology, are appropriate candidates for this exam. This technique can also be used as a screening exam in high-risk patients. A probe should be selected that has the ability to see deeply into the abdominal cavity. The best choices for this exam are the curved probe or, if available, a phased array probe. The abdominal aorta runs from the diaphragm to its bifurcation at approximately L4. A thorough exam requires visualization of the aorta from the diaphragm to the bifurcation. Begin scanning just at the xiphoid process, where the liver serves as an excellent sonographic window. The transverse plane allows for visualization of the adjacent inferior vena cava. Use the anterior cortex of the vertebral column as a landmark. Carefully follow the aorta caudally until the bifurcation is seen at the level of the umbilicus. The aorta should be examined in the longitudinal plane throughout its length. This view will allow for visualization of the superior mesenteric artery, or SMA. Notice that the aorta gradually moves anteriorly as you descend from xiphoid to bifurcation. This is due to the natural lordosis of the spine. Bowel gas causes scatter artifact and is the most common obstacle in adequate visualization of the abdominal aorta. Throughout the exam, moderate steady pressure may be required to disperse overlying bowel gas. Here is a normal aortic exam. Note that in the transverse view, the inferior vena cava is seen adjacent to the aorta on the left side of the screen, corresponding to the patient's right. The inferior vena cava is thin-walled and elliptical. The abdominal aorta is round and has thicker walls. The anterior cortex of the thoracic spine can be seen in the far field. Slowly sliding the probe inferiorly allows visualization of the abdominal aorta throughout its full length. The lumen of the aorta can be seen to split at its bifurcation into the iliac arteries. The longitudinal view allows for visualization of the superior mesenteric artery anterior to the aorta. The renal arteries take off just caudad to the SMA. Freeze the screen to measure the diameter of the aorta from outside edge to outside edge. In the positive exam, dilatation of the aorta beyond 3 centimeters diameter is seen. While the majority of AAAs are infrarenal and therefore identified below the SMA, it is critical to visualize the most superior portion of the abdominal aorta to obtain a complete exam. Here we can see extensive thrombus adjacent to the wall of the aorta in both transverse and longitudinal views. Here is an example of a suprarenal AAA, which could be missed if the full length of the aorta was not visualized. Measuring from outside edge to outside edge is especially important, as the apparent lumen of the aorta may appear much smaller than the aneurysm itself due to the presence of mural thrombus. You perform an ultrasound exam of the aorta to search for AAA in your patient with flank pain and hypotension. A 7-centimeter aneurysm is identified. The patient is resuscitated and taken to the operating room for an exploratory laparotomy and repair of the ruptured aneurysm. When conducting an ultrasound exam of the aorta, be careful to avoid mistaking the inferior vena cava for the aorta. Use steady, gentle pressure to minimize artifact caused by bowel gas. Be sure to scan in the transverse and longitudinal planes, and to visualize the entire length of the abdominal aorta, from diaphragm down to its bifurcation. Ultrasound evaluation of the aorta is useful in a patient too unstable to be transported to the CT scanner, as well as in the stable or asymptomatic patient to identify abdominal aortic aneurysm. A dilatation of the aorta greater than 3 centimeters in diameter is considered an aneurysm.